Hi, my name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Conference in Las Vegas, Nevada, and I'm joined by Dr. Matera. Dr. Matera is a nephrologist, and he's going to be speaking on chronic kidney disease. He's from New Jersey, and that's where he practices. Yes. Welcome, Dr. Matera.
Thank you, Dr. Shahady. Thank you for having me back again this year. It's a great conference, and I'm pleased to be speaking here again.
Excellent. You know, it's only been, I guess, what, the last decade or so, we've really had some good guidelines about chronic kidney disease, chronic renal disease. I, as a primary care doctor, what do I need to do with my patients? Are there certain patients I should be looking at that are more likely to have chronic kidney disease? What can I do to screen them?
That's a great question. And that's actually what we'll be talking about a lot tomorrow. I'm trying to put forth, a lot of people get afraid when a patient develops kidney disease. Mm-hmm. And if you look at some of the data, they shy away from some of the chronic kidney disease treatment programs, and they shouldn't. The nephrologist should be your buddy. He should leverage you to help you care for those patients. Right. So the guidelines that have come out have addressed lipids, so we'll talk a little bit about that tomorrow, but also to try to limit the downside of chronic kidney disease, because we all know our patients are the highest spend. If with all this alphabet soup out there now with ACOs, you look at the spend for an end-stage renal disease patient, and it's 10, 15 times what it is for the regular patient. So we have to do better at monitoring these things.
Yeah, the other thing that I sometimes get stumped with is which formula should I use to get the GFR? There's the CKD epi.
Yes.
There's other ones to do. So what do you recommend in primary care we use?
Well, right now, the two that are most common are the CKD, the MDRD study, which comes out on most of the labs. Right. And then there's the CKD epi, and we'll look at that tomorrow. That's maybe a little bit better for a frailer patient because it doesn't really count in muscle mass. Right. But neither one of those counts in weight. Okay. And that's a big downside. So they tend to underestimate GFR. So for right now, I think we're looking at that, but I'm also going to show some slides on some novel markers that are being looked at that may do a little bit better. Right now, I think the MDRD formula is what we use. What I tell my pharmacists, because we do a lot of protocols with them, is if they do the Cockcroft and Galt, which does take into account weight, and they have that in the MDRD, and they have to dose-adjusted medication, I tell them to opt for the lower one, just to be on the safe side. But the MDRD is the most common one. For drug calculations, the pharmacists like the Cockcroft and Galt with the weight test.
Okay, you mentioned, have a good relationship with your nephrologist. So I'm measuring, GFRs, but no matter what, system I use. Mm-hmm. And where should I think that this is? I better be talking to a nephrologist now. Is it a GFR 45? Is it 30? Is it 15? What do you recommend?
Great question. Most patients get to the nephrologist 1 month before they require dialysis. And that's a scary thing because we'll show some data tomorrow that there's really not much to do at that point. The current guidelines, and again, we have a little bit of a disjoint here because if a nephrologist sees a stable 3A patient, he doesn't have to see that patient more than once a year, if not even just a single consultation. But he has to work with the primary care doctor to give him guidelines on when that patient needs to come back. The ball game is won and lost at about stage 3B to 4. That's when the primary care doc should be referring patients over, because that's when we start to look into a lot of the things that happen with advanced chronic kidney disease, including, which is very important, preparation for dialysis. And that's a sore point in nephrology right now. If we just started, for instance, a patient on dialysis with an AV fistula, the cost to the system is $18,000 less than it would be if we started with a catheter.
I see.
And these are things that we have to teach the...
So I have to get them there. And you should have mentioned 3A, 3B, and so I guess that's between 60 and 45 3A, 45 to 30 3B. So I should be thinking when they get into 3A, at least consulting anything below 60, consult with a nephrologist at least once?
Or at least, yes. Here's the way I'm moving my practice in the direction, is when they get to 3A, I'd like to see them one time. And I can then go over a lot of the things we'll talk about tomorrow. When do you start worrying about their parathyroid? When do you start worrying about their phosphorus? because many times primary care docs will shift that work to the nephrologist, and there's a disconnect. And I'll actually show a really good slide on some of these things tomorrow. So I want to erase that disconnect. I want to put the primary care doctor back in the driver's seat. So 3A is a good referral point. My 3B patients I'll see once a year as they're in the lower stages of 3B, twice a year. And then after that, stage 4, I usually see 3 times a year.
Okay, you mentioned parathyroid, and there's vitamin D, and there's calcium, and there's bone density, a lot of issues. Is that something the family doc, the primary care doc should be think of, or is that something we let the nephrologist do?
Great question. And I think that the primary care doc needs to at least be aware of what's going on in that realm. And that makes it very important, because then they'll understand the downsides. Do I expect them to understand all the sequelae? Absolutely not. But I'm going to show some hard, fast cardiovascular mortality data that couples with phosphorus levels. There is no doubt that once the patients start to develop high phosphorus, it doesn't have to be over 5.5, it's in the higher ends, their increase in their mortality goes up.
So when should I be getting it? If somebody's below 60, should I be getting phosphorus? Okay.
And I actually
is that for baseline or decision on referral, or for what?
There's a way you would look at it. My 3A patients, I do it annually, and my 3B patients twice a year.
Okay.
And I actually posted on our Twitter account a kind of a table that downloads all these things. So if anybody downloaded the app, they can go to my session and look at this table.
Excellent.
And I'll be showing that again tomorrow. But that also covers that. Parathyroid, probably just once a year, you know, and then we take care of that. But
and that's once they go below 60, I start triggering at least to obtain all those.
Absolutely, and that's your marker. Once you have a patient, and 97% of the patients that you're going to see are going to be stage 3, just purely by age. You know, a person with normal renal function would be classified stage 3 even if they were in their 80s. But again, they may not have kidney damage. So we're classifying some patients with chronic kidney disease when they really don't have that.
Let's go back to prevention. I guess when you say that looking at urinary albumin excretion, you know, creatinine albumin ratios, or their blood pressure, isn't that the best way for me to prevent the majority of what I'm going to see in my family medicine practice?
Yes, proteinuria is by far and away a risk factor, and there's no doubt about that. And that in and of itself, even someone who has a normal GFR, if they have 3 months of proteinuria, they have kidney damage. So they would be classified CKD, even if it was stage 1. If their GFR was 95, but they had proteinuria, they are still CKD. A patient who has a GFR of 95 with no proteinuria, no hematuria, they're really not chronic kidney disease, and we have to be careful not to label them as that, because that plays into insurance issues and things like that. But certainly, once you get into those realms, absolutely, proteinuria is absolutely a marker of progression of kidney disease.
And does that see mostly in diabetics, or do you also see it in hypertensives?
We see it in hypertensives as well. Diabetics tend to get larger amounts of proteinuria, and I find that we mask a lot of the proteinuria because we're so good now at using ACE inhibitors and ARBs. If the patient wasn't on that, I don't know what their protein would be. It could be much higher.
Let's talk about morbidity and mortality. I think that, because you know, not everybody goes on to develop end-stage renal disease, and I guess cardiovascular mortality is the big issue for it. So how do I address that? At what point should I be getting lipid levels, and how should I respond to it? Can people who have chronic kidney disease take lipid-lowering agents?
They can, and there are actually some KDIGO guidelines which we'll look at based on age and comorbid conditions. They actually used ezetimibe and I think it was pravastatin in their guidelines for some patients. Patients who are at stage 4, the guideline right now is if they've been on lipid-lowering agents, okay, but if not, it won't give any added benefit for the kidney aspect. But there's really been no hard and fast studies that saying lipid-lowering has improved mortality from renal.
The SHARP study doesn't prove that?
It does to some degree. A lot of people have some interest in that. Because I think that it does. But, you know, it's always got to be taken with a little bit of grain of salt with these things. Just as we just saw in the last week, the hypertension guidelines took a major hit this week with the NICE, you know, protocols. So those are the things that we want to look at. But clearly, I think, you know, cardiovascular mortality is what end-stage renal disease and chronic kidney disease patients die from.
Well, one more statin question about, I think the dose of statin and chronic renal disease, because myopathy is going to be more common. So do I lower my dose like 20 milligrams of simvastatin, 10 of atorvastatin if I'm going to use it? What's your recommendation?
Yeah, I usually go with a lower dose to start with, but I will titrate up if they have no symptoms.
Okay,
I'm going for the same lipid-lowering agent, levels that we want in our other patients. Dialysis patients are interesting. The guideline actually says if they're on statins, okay. If they're not, probably no benefit.
Right.
But the chronic kidney disease patients die of cardiovascular mortality.
Okay. Well, that's fantastic. I appreciate you being with us, and
thank you.
Look forward to your talk tomorrow.
Thank you very much.